fact that we now have a documented reason for infection to be at high, for us to be at high alert, means that all we need to do is ramp up our level of suspicion and our protection. So we would not, the worst thing to do is you don't turn a patient away who is unstable because you are worried about them potentially infecting you. The proper thing to do, which is what we do, is we mitigate the risk of getting infected. Certainly nobody is God, so we're not, even the best masked, the best person using PPE, the most cleaning, you still cannot prevent the possibility of infection. And our doctors may walk out into the community and become infected. There is a thought that at the end of this, at least 80% of the population will be infected regardless of our best measures. So what we do is we first assess what is happening with the patient and prioritize in terms of what could possibly end that person's life quickest. And that is what we deal with. If it is cardiac, then that's right up our alley, and we deal with that. If it is not cardiac, and there is a center that is best poised to deal with that, we would then discuss between us and that center about whether or not they would be better suited, and either discuss a transfer or discuss a consult, because that is also possible. That person could also come on our premises and provide a level of care that that patient needs. But first of all, we need to make sure that that patient is stable, and at that point, then everything is fair game.
Okay, thank you. I just want to remind our participants that now is a good time to send us your questions. So Dr. Ball, so she can speak to as best she can to whatever concerns that you might have. We should also say that standing by we have Dr. Ernest Madu, and he will also be able to if needs be, he will chip in. But primarily, we're focusing here on Dr. Ball. Persons who are not in a hospital setting, how can you advise persons who are caring for them at home, let's say? Mm-hmm. What are some of the things they need to be mindful of?
Michael, this is scary, but it's not rocket science. The same thing we would worry about for ourselves in a hospital. You think about it at home as well. You're uninfected, someone else is infected. Let's say it's with COVID. You still want to make sure you're hand washing, observe, sanitary practices. Every time you touch something, you make sure you wash. Avoid your eyes, your nose, your mouth. So you really don't want to bring anything that you've touched into your body, because that increases the risk of infection. Wash. I can't tell you how many loads of laundry we do on an ongoing basis. You wash till you're tired. And if you do have access to hot water, wash in the hottest water that you possibly can. Because we have free sunlight and the sun is burning bright, and we do know that the virus is heat and temperature sensitive, hang your clothes out to dry. Take advantage of the resources that you have. So sanitation is just one of the best ways to keep healthy. Mask the person who has the disease, and you mask as well. Wearing an at-home protective mask, like the cloth masks that everybody is talking about, no, it's not going to be 100%. It is not the answer. It's not as protective as a surgical mask, which is not as protective as an N95, But if I wear a mask and you wear a mask, you're protecting me and I'm protecting you. So you can put that into play at home as well. And I think that those are just the smart things to do.
Okay. Let's see if we can maximize the amount of time we have left here. Elective surgeries and routine visits to doctors have been, significantly reduced, or in some cases, non-existent. What advice would you give to women who may have delayed visits to their OBGYN, for example? And also, let's just throw in mammograms in there during this time.
That's a dilemma. I know people are talking about, even across the world, open up, because we want to be able to do mammograms. And what about the breast cancer we might miss as a result of being in a prolonged period of shutdown? I think routine maintenance probably should and could wait until the pandemic is over. Let's move this though to, let's say you have an issue and you are unsure, you're uncertain whether or not it is urgent or emergent. Remember that the patient doesn't always know. Something the patient thinks might be the end of the world. They will call and we'll say, oh, this is nothing. And then they say, can you imagine? I go and I sit down for and she just tell me it's nothing. Or it might be something that the patient sits at home and says, oh no, it's absolutely nothing. I think I have a little gas. And turns out that that gas is a massive heart attack and you had no idea. So for me, what I recommend to people is don't guess unless you have been through years of medical school and years of residency training and then years of fellowship training. There's somebody better positioned to tell you whether it's urgent than you. Pick up the phone. Call. If you are having chest pain, the best place to be is not at home. If it turns out to be gas, good for you.
Good.
But but let me tell you something, gas won't kill you now, but delay will. So you want to make sure that you decongest the system, and then the people who are doing life-saving things that in an urgency, minutes count, you want the medical arena to be able to handle that, which is why we have to continue to be available.
Yeah, ironically, it was years of having various conversations with you in different programs like this, that when I was having my chest pains, I wasn't thinking gas pains. Unfortunately, it wasn't gas either. So I know from whence you speak. So,
Michael, the funny thing is, it's one of the things at the back of my mind that I'm always happiest about, or not happiest, but proud that, I remember us talking on your radio show a lot about, people in Jamaica always, you're having chest pain, you go drink tea because you think it's gas. Oh, I just need to belch it off.
yeah.
When you had that, you said, no, cardiac. And I said, yes, clearly we're getting through to somebody. And so in an instance like this, where there's so much chatter around so many other things, everybody's focusing on COVID. Everybody's focusing on infection. So many other life-threatening and urgent things are going under the radar. People are dying at home with heart attacks. That's a mistake to make. Don't worry so much about possibly getting infected from COVID. Worry about what you're going to certainly die of if it's unaddressed.
Okay.
Patients
Another quick.
Michael, I want to say this quickly. Patients are also coming into facilities, and we are so tuned into COVID that every cough now and every shortness of breath to us is COVID. And doctors and medical staff are making that mistake and siloing patients and therefore missing the forest for the trees. Big mistake, and I think that it's important to say it.
Okay. What are your thoughts on, and this is from social media, what are your thoughts on video visits?
Video visits. I like them. In fact, I do them. I don't know, well, you know that I practice in the US and I practice in Jamaica. And one of the biggest things that when I whittled down my US practice, I can't come to Nashville without running into somebody, or my mother still lectures at university and she will run into somebody and she says, oh, I didn't know you know XYZ. I said, yes. She said, oh, you know them? I said, oh, I just know them because I'm still keeping confidentiality. She said, she used to be your patient and she misses you. And so over time, I've been forced into continuing to see patients to a certain extent, and I have been using telemedicine to do that, video visits. It is valuable, especially in the setting where you can send the patient off. If you need diagnostic testing, you can send them off to get them. If you need to send a prescription, it's simply just the touch of a button and the prescription that I've written go to the pharmacy. And you know, patients who intend to do that in any serious way may have their blood pressure monitor at home. There are even little ECG machines that you can have and just put your, and I can see the ECG. So I find there's value to it. We also do televisits in Jamaica at the Heart Institute, and especially now, it is a vital part of making sure that people who have pre-existing conditions, or if you're worried that you're at highest risk for COVID, you don't want to go out, but you need to see the doctor. That is a way that you can see the doctor. It's a doctor in your pocket. So I find that it is very valuable.
Okay. I just wanted to also ask you very quickly about persons who are, you know, this is a very stressful period for people right across the globe. And so what I'm curious about here is, you know, there's a lot of anxiety. And of course, you know, the stress levels are very high. Very quickly, what would you share with someone who might be in that situation? And I suspect there are a lot.
Breathe, breathe. I tell people,
breath.
Yes, breath. Yeah. You know, it's my thing.
Yeah.
The more you know, the calmer you should be. I tell people, though, don't go down the wormhole of trying to find out every little detail about every little thing as it pertains to COVID. One, many people don't have the scientific background to filter out the noise from the meat of the issue, and find that they're getting panicked. Because I can't tell you how many emails I get, or even visits about, oh, now they say there are 30 different strains. Does this mean? Some of the things you just need to take a breath and be still. Recognize that the people who are looking at this virus are also as invested in getting it right as you are. We have our own lives to save as well. So listen to the medical information, but don't get too focused in on every little nitpicking detail. More so though, Michael, interesting.
We should not let go for information, because I mentioned last week, and I'm a firm believer in this, replacing fear with facts. So if you need to check something, instead of going to your good friend who's a good accountant, you know, but won't necessarily have information on COVID-19, where would you suggest that folks go? Where do you go for information?
Well, you know, even that is a thing that we do. I know Dr. Madhu and Dr. Edwards, who are both consultant cardiologists here, every week they have been writing an article. Yes, so they've been writing an article for the Observer, and it breaks down what you should worry about or what you should know, and it comes out in the Sunday Observer. Read that, it gives you information. You can go to the Johns Hopkins website, johnshopkins.org. It tracks the virus, tells you where it is, how many are there. In Jamaica, the Ministry of Health has a website set up. They do press conferences and briefings. Look at that. On your iPhone, I know there's a news app, and on that news app, there is something that's specifically for COVID-19. I would look at the stories that are above the lead. So don't keep digging deeper and deeper and deeper where it now becomes very anecdotal. The things that have the weight of more evidence are there. Leave the heavy science to us because we know what has little power. Like, oh, they only did that with 1,500 people versus 50 people. Let us do that heavy digging for you, and you don't worry so much. Go with what you know and rest in what you know.
Okay, I'm going to stop you here, Vinya, because we're at the end of our time. But next week, we have a very exciting guest, yourself, and that guest will be here. Could you tell us quickly a bit about who she is and her background, and what would she be talking about?
Yes, well, it leads right into this thing about replacing fear with facts. And so next week, actually next 2 weeks, we'll have very exciting guests. So next week we have Bina Venkataram, and she is an editor for the Boston Globe. And she has had a long career in reporting. Previously, she was at the New York Times, and she does a lot of science and health reporting. And so she's had some hard-hitting articles recently about governmental response to COVID-19, and just about data in general, how we collect data, how we know what is true and what is not. And so next week, we will have the editor, one of the editors of the Globe there.
Yeah, I'm looking forward to that. Should be very exciting.
That's going to be exciting. The next week, we are going to have Dr. Chinyere Aniago, who will be here, and she is actually on the forefront of the fight because she runs an OB/GYN program in New York City. So she
Wonderful.
is, yes, vice chair.
All the questions to do with pregnancy and pregnancy.
All the questions to do with pregnancy.
We're planning to have getting pregnant and that kind of thing.
I'm telling you, she has continued to, of course, her team has continued to deliver in the middle of this pandemic. What did they do? Women's health issues in the middle of pandemic. That question you asked about mammograms, she's answering that every day. And so we're really excited just to kind of spread the talk.
I have a raft of questions for her already. I mean, like, if you're thinking about getting pregnant, should you wait until after COVID-19 if you're trying now? All of stuff like that.
You're too late, Michael. Listen, all this lockdown, we're going to have a bunch of quarantiners and COVIDios coming up.
Okay. Dr. Daniel, as always, a pleasure chatting with you. Good to see you. Stay healthy and well.
Thank you.
And we'll talk again next Tuesday. That's May 5 for our next program. Okay, so that's it for us. I want to thank you very much once again. We tried our best to make up for our technical delay, and I sincerely hope that you were able to glean a lot of information which you'll find extremely useful in getting us through this period. Please continue to stay safe, and of course, remember, it's all about social distancing. Okay, and I'm just being told some good news that we understand we have some more time.
Oh,
yeah. I understand we have some more time, so that's great news.
Okay.
I was just on the verge of wrapping up here, but well, let me just forget about that. Just take some time here to remind you that if you have questions, we've got answers. So please type them, or raise your hand, and we will definitely respond to you. We're waiting here. This program is about you, and so therefore we are expecting you to take advantage of the opportunity. I was asking that question I was saving. We'll still ask it of the OB/GYN OBGYN. But let's say, for example, Dania, a couple is trying to get pregnant.
Yes.
Would you advise them to continue at this time or wait until after the isolation is over, that period?
You know, certainty is always a good thing, but we don't anticipate that we will be in surge territory for the virus for another 9 months. Like, we're not going to be on continuous lockdown with persistent high virus in the population unchanged for 9 months. So remember, if you get pregnant today, we still have 9 months at which we will have a break in this, hopefully. Um, I just don't think we know enough about the virus and what will happen for us to make life-changing decisions based on it. We expect to have another wave. We expect, for example, in the States and in Europe, and I think probably all over the world, for this to come back again when it gets cool in the winter time. Um, you know, there's some data that came out with a predictor of how long it will stay in each population. And I think that the guess is that by December 2020, it should be 100% gone from the world.
Yes.
But we don't know that to be sure. And so for something as important as whether or not you have children, especially if you're in that age that your clock is ticking and your hormones are changing, I would say live your life. That's my guide. Live your life.
Let me ask you this question on behalf of Clandine Thomas. She says she'd like to hear some more about how we can boost our immune system, how we can fortify our bodies and mental capacity.
Okay, that's a really good question. I think everything starts with your diet, and I am a big food as medicine person, and I don't recommend us waiting until something is happening to then start to bolster our diets or our supplements to ward off COVID. I think you start with a certain foundation that comes with being active, even if you're not an exercise person, being active, eating fresh leafy greens, as much of it as you can, lean sources of protein, and to keep metabolically well otherwise. So if you're doing those things, that means that you're decreasing your body weight in general, you're decreasing your risk of heart disease, you're decreasing your risk of diabetes. All of those things you're already doing. So then when you're looking for how do I add to that in terms of a pandemic or dengue is going around, you're not starting from zero. So you're adding. My biggest thing is vitamin D. I think it almost should be in the water, but it is in the sun. And so a certain amount of sun exposure I find to be healthy. We have so low vitamin D, especially in people who have melanin. And no matter how much sun we have, it needs to penetrate our melanin. So I like about 10 minutes of sun exposure, outdoor sun exposure every day. And that raises our vitamin D a lot. And vitamin D helps prevent viral replication. It boosts immunity. Lots of things. People love vitamin C, but I think vitamin D first. A good multivitamin. And then you can add like your vitamin C's and other things like that, and get deeper and start talking about elderflower and other things. But I think a foundation, an omega-3 fatty acid, vitamin D, and a multivitamin, drink lots of water, eat your vegetables, and exercise.
Dania, I'm embarrassed to ask the next question, but I think I should, in all fairness. Drinking Clorox. Drinking Clorox. Yeah, you heard right.
Yeah, Michael.
Clorox or anything else that, it's, yeah.
You know, it is important to note, don't do it. Never a good idea. Now, those of us who live in hurricane and flood zones know that you can purify your water with a certain amount of Clorox after a hurricane, for example, if there's turbidity and you need fresh water. When you therefore hear somebody saying, oh, perhaps we can imbibe or bring in disinfectants, people who have that kind of background knowledge in our lizard brain might interpret that to say, oh, that makes sense. Certain people also have been doing this Clorox, this bleach baths, and you think, oh, that makes sense. And so you're tempted to think that that is sound clinical or medical advice. No. I've seen a meme going around and I thought, God, I should be so bright to create some of these memes. I would do it. And the best meme that I can answer that with is the medical term for ingestion of disinfectant is called embalming.
Okay.
So
Yeah, yes. Next question is from Jillian Ferguson. Hi, Jillian. She says, how about the BCG vaccine? Any truth to us in the Caribbean who have gotten it as children?
Okay.
What's the story on that?
Listen, the non-proven thing that I want to believe is that, yes, it is helpful for us and that it will make our disease course milder. There's been a lot of early data coming out that suggests that the BCG vaccine helps. I do not think that that is proven, and I think it will be retrospective, where we look at kind of who had the disease, how many people had the disease, what their what the severity was, what the complication and mortality rate was, and then match it to who actually had the BCG for us to know. What we do know, though, is that the BCG vaccine it is an immunopotentiator. So we know that it actually improves the immune response in other things other than what it was intended to do, which is tuberculosis. So the hope, of course, is that we can extrapolate it and say what we've seen early signs of is that BCG is helpful and that it will decrease the severity of the disease, and that those of us who have had BCG will have less mortality. Don't put all your eggs in that basket. Still do what you know you need to do, and just know you have an ace in your pocket.
Okay.
That would be my opinion.
There's a question here from GW, and GW is asking, what if you are hypertensive and you contract COVID-19?
Okay. From all indicators, it increases your risk of having complication. We're not even going to go down all the reasons why. There's some question of ACE2 receptors and all of that. It increases your risk of having bad outcome, and it increases your risk of contracting COVID. Having said that, I think the messaging for us will still be the same thing, which is try to prevent it if you can. So we're not telling hypertensives to do anything different than we're telling somebody who is 20 years old, or we're telling our grandmothers. What we're telling people is hygiene, 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 sanitation, social distancing as much as you can. And then, of course, as I would tell anybody, if you have high blood pressure, you need to make sure that it is controlled. And that is whether or not COVID is here or not. Because remember, when COVID has come and gone, heart attacks are still living on. Heart attacks currently are still the #1 killer of everybody. So when we get into this tunnel vision and this wind tunnel about COVID, and we're thinking, oh, what about my high blood pressure and COVID? No, your question really should be, what about your high blood pressure and heart attacks? What about your high blood pressure when you're pregnant and eclampsia? And what about my shortness of breath and perhaps my cough, and I'm feeling like the baby is sitting up in my lungs? And instead of me thinking, oh, it might be COVID, let me think that this might be pressure, this might be eclampsia. Let the doctor check, ECG, let him check urine, think of, just because we have COVID, let's not forget that we are doctors first. We're not just virologists. So I think if I can leave anything with you today, and it's that all the health issues that we have continue. They have not taken a break just because COVID is here. Even though we say outside not keeping, disease is still keeping, even though we have COVID to think about. So that's
a question I came across many years ago, and it's always applicable, and it's this: who mothers mother? We have been talking about, we've been getting advice from you and the panel over the weeks, and I think of the persons on the front lines who are, they're just doing the work, and they have families too, they are people too. What do you say to health workers like yourself? What do you do? What do you have to remember? What would you say to your peers listening in? And we do have a lot of doctors listening in.
Let me tell you, you talked about the stress of COVID on the average person. And I'm going to take it in stages, in terms of, there are some of us who are on the front lines, and I would not consider myself somebody on the front lines. I see Dr. Suleiman and Dr. Tollereed here, and I would say that they're on in the orbit of the front lines, because what that means is they continue to do caths. Dr. Knopp continues to do bypass surgeries, because those things don't wait. Those emergencies don't go away. And you never know when somebody comes in, what they're bringing with them. So that is front lines. But then inside that orbit are the people who are actually working the COVID wards. You have the anesthesiologists, up at the University Hospital. In the States, you have rank and file thousands and thousands and thousands of healthcare providers on the front lines. And the mental toll must be unimaginable. I was talking to Dr. Madhu just the other day, and I said, the biggest thing that this COVID is going to unmask is, I wouldn't say it's a thankless job, but how much psychological turmoil there is in basically standing in the gap for people. And yesterday that manifested with the director of emergency medicine at one of the hospitals in New York City, contracted COVID, recovered, went back to work, and was not doing so well, and went home to her family, and she killed herself. The psychological turmoil of seeing hundreds of dead bodies every day. At a well-run program with people who know what they're doing, you come to the cath lab, you come to our cath lab, we haven't had a death that on the table. It's not something that should happen. If it's happening, it means that something's wrong in the system. You either need, retraining, reorientation, or something's wrong in that handoff. So think about, if you are somebody who's used to seeing 2 deaths, maybe a shift, and that's a bad night. And then all of a sudden, people are pouring out of the ambulances and they're dead on arrival. You're intubating people in the hallways. You know, we're talking in Jamaica about, oh, we don't have an isolation room. Well, you know, the emergency room is not an isolation ward. You know, there are no negative pressure rooms when you're treating thousands of people. You're doing the best you can with what you have. And that pressure is unimaginable. And I think there is no answer except that we're going to have resources available for the emotional well-being of physicians and nurses too.
As a physician, then, because I don't think in years we have seen anything like this, like COVID-19.
No, you're right.
What has this disease taught you about medicine as a physician?
You know what it has taught me, Michael? It has taught me that my mother used to always say this thing that man a plan and God a laugh. It has taught me, seriously, it has taught me how little we actually know. It has taught me that even the best minds can still be surprised. It has reinforced for me that medicine is a team sport. I just, you know, and it's something that I've even talked to you about in the past, in that for so many years, especially in Jamaica, people have thought about, oh yes, man, no man, doctor such and such, she might a boss, the best doctor, you have to go to, but doctor such and such, his team may not be as strong as he is. He may not have the tools that are 21st century tools, and he's dealing with 19th century tools with his 21st century mind. Medicine doesn't exist in a vacuum. The doctor is only as good as the system. The system's only as good as the supplies. You know, all of a sudden, we have seen that the so-called giant of the free world, the emperor is naked. And why is the emperor naked? Because the system broke down. The doctors are as good as they ever were. The nurses are as good as they ever were. While everybody else around the world, some of us are running away from the disease. American doctors are running towards the disease. You don't have people saying, no, I'm afraid, so I can't go to work. But if you don't have what you need, if you don't have personal protective equipment, if you don't have the ventilators when you need it, it's a system, and the system has to work in order for medicine to work well. And I think that is what it reinforced for me. That's what we've spent, I think, 15 years creating at HIC, a system. And that, Dr. Madu can speak to it. Like, I woke up one morning and I said, you know what's true? The system is what counts. We have a medical group that we talk about data, and we talk about what research is coming out, and we discuss patients. And I remember sitting there writing a whole diatribe about why the US was having so many issues, and you know, why Jamaica may actually do better and all of that. And I remember Sully saying, well, that might need a paper. You might need to write up. You might need to write up. But it's true. And I think that is my take home point. The system counts. You're muted, Michael. There you go.
Yes, you mentioned Dr. Madu just now, and I think it's a good time because the next question would follow on the heels of the one I asked you about, you know, doctors on the front line. When you get together as a team and you're discussing this COVID-19 disease, what are some of the questions that you are asking yourselves? Dr. Madu, you want to get in here?
What are some of the questions we're asking ourselves?
When you talk among your peers, what are some of the things that you're still baffled by? Because this is a novel disease, huh?
Well, I can show you. I mean, this is our medical group chat, and
really,
yeah,
okay.
we talk about the actual infection that's silently killing coronavirus patients, and about how the lung, is it actually a perfusion problem or is it an oxygenation problem? And we go into the data about why we believe one thing versus the other. Dr. Madhu can talk about other things if you're ready.
Okay.
Okay, so can I speak?
Mm-hmm.
Welcome, Dr. Madhu.
You want me to comment on it?
Yes.
Yes, please.
All right.
Yeah,
So,
I know there are many. The questions at the top of your list when you guys talk.
No, there are many questions, that we kind of contend with, but Dr. Barr has touched on it. Maybe Dr. Barr can be to.
Oh, sure.
Okay. So
I'm hearing you fine.
Can you hear me?
Yes, I'm hearing you fine.
So one of the things we contend with is what Dr. Barr already kind of spoke with. Everything revolves around it. And we think, the fallacy, which has been perpetuated a lot, particularly in developing countries, is that, you just need good doctors and you just need good nurses. That's a fallacy. You need good doctors, you need good nurses, but without a good, well-oiled, functioning health system and infrastructure, you have nothing, right? Because when that system is stressed, it will collapse very quickly. As we can see, one of the things that is sustaining kind of like life in America is because the health system is organized and functional to a large degree. We still have a lot of work to do to make it more accessible and more affordable for the large majority. But the biggest problem is a disorganized health care system. And the biggest problem is when the people within that health system or within that community don't even recognize that it's flawed and it's disorganized. Even all the story we're talking about, the unfortunate incident that everyone in Jamaica is talking about now, you can't address those kind of situations without looking holistically at the health system itself. A health system that holds people accountable, a health system that demands certain level of professional excellence, right? A health system that demands documentation of what we do to make sure that everybody is following established and recognized international best practices. So those are the things that matter. To just round up my comments, I'll say one of the biggest things that you'll hear about, everyone is talking about ventilators, because that is the new mantra. Everybody's talking about ventilators don't run themselves, right? Ventilators will need ICU space that's already provisioned in the infrastructure. Ventilators require a lot of other associated things. Most patients on ventilators are constantly sedated so that they don't pull the ventilators out. Those persons, if they last too long on the ventilators, they might need parenteral feeding, where you may have to put a line so that you can feed them through there. They will need arterial blood gases. All of those things make up the care of the patient in the intensive care unit. So it's not enough to have good doctors. It's not enough to just get ventilators. You have to have an entire well-developed healthcare ecosystem.
Yeah. Well, very quickly, how close are we, or where would we be to the tipping point in terms of our system? Because I know, for example, in America, that they really don't have enough spaces to accommodate the inflows of patients. So they're pretty much hit their tipping point.
Okay. So let me answer that question. Yes and no. Now, remember, there was a projected, based on the virulence of the disease and the prevalence, how many people we thought would be affected. There was a projected number of how many people would have it in a certain amount of time. And there was some panic about the fact that the system would be overwhelmed. And for a while, the system was overwhelmed in the US. What has happened though is that with the social distancing and other measures put in, the curve did flatten. And the purpose of that was to make sure that so many people weren't going through the pipeline at the same time. So even though they built additional hospitals, field hospitals, they turned St. Patrick's Cathedral into a church, into a hospital. The ships came off, the Mercy and the Comfort came off offshore. They actually did not need all the resources that they ramped up to. So they did not completely tip. There was a thought that they would need 30,000, I think, ventilators, and ultimately did not need that. So what New York has now done is move those ventilators to other areas of the country where the surge is projected to come next.
Okay.
So that is a short.
Yeah, Dana, you said that you wanted to take maybe just one more question before we wrap up.
I saw somebody asking, and I thought I didn't want to leave without answering.
Is this the one about her husband who
Yes. My
had been
husband
having
has
chest pain from last year and went to the doctor and can't say what it is?
Yes.
And if you ask him for some advice, yes.
So I would say not being able to say what it is presumes that he did the right test to know what it is. So if you come to me with chest pain and I do a chest x-ray and I don't see anything, I haven't even begun to look at the most likely causes of your chest pain. So if I tell you, no, I don't see anything, doesn't mean that that there is nothing. So even if I did, for example, an ECG is a static thing. It tells me what is happening now or what has happened in the past. It really doesn't have high predictive value of what could happen tomorrow. So a normal ECG, you could still go out next week and have a heart attack. Long story short, please, that was last year, today is no. Please have him go and see a cardiologist to find out what that chest pain is. If it was, you can choose. My recommendation, of course, I'm biased. Come in, see Dr. Suleiman or see Dr. Edwin Tullereed. The experience, the skill, the system, and that would be my advice, right? Somebody asked me about my mental health. You know, listen, my short answer is as long as I can sleep and I have a book, I'm good. So when things start getting, too much, I breathe, and there is I actually breathe, and then I tune out. I actually turn to something else, almost like changing the channel. And the way I changed my channel is I start reading and I read something fiction. So that's how I preserve my mental health.
Does being married to another doctor help?
No. No, Michael, no.
Don't answer that.
In fact, what happens is that these conversations continue constantly, especially a doctor who functions at the level of Dr. Madhu. Like,
Ernest, go away.
trust me. Oh, do this research. Tell me what this person was saying in 1984 in this paper. We're writing a paper to submit to the New England Journal. It's constant. And I think all of our doctors know. In this time,
guess what I just thought about? Yeah.
It's a lot.
Okay, so it's not a good thing, eh? Look, man,
it's a great thing. It's a great thing, but it does not give me any increased comfort about COVID.
I understand. Physicians, heal yourselves. Thank you very much, Dr. Daniel Ball, Dr. Ernest Madhu. Hi, thank you very much. And And thanks a lot to everyone who participated. I know Dr. Edwin Tullereed and Christine was in there as well. So hello to the Tullereeds and all the other medical personnel, the folks on the front line, and to all the folks who participated. Thank you so very much. Patricia, Reed, Waugh, thank you so much for being there and for being a part of this. Remember, we'll be back here with you again on May 5, right, which is next Tuesday. And at that time, we have some very exciting guests coming up, and you will be able to be enlightened with, with the state-of-the-art information, all right? So on behalf of the folks at the HIC Hospital, we'd like to thank you very, very much for being a part of our programs here on, COVID-19 and the Heart series. I'm Michael Anthony Cuff. Thank you so very much. You stay safe. And remember now, it's all about social distancing, not emotional distancing, all right? Unless you're married to another doctor. Don't ask any more questions. Bye. See you next time, guys. Okay,
Thank
bye-bye.
you.
Thank you.